Thank you. Today, this is our 7th session of our perinatal mental health tele-echo. I want to welcome everybody. My name is Jody West, and I am the coordinator. This is our agenda for today. We're going to do our best to follow this schedule. We'll do brief introductions, and then Dr. Megan Vincent is going to present our didactic. And then we'll have a case presentation by Andrea Stradley, BSN RN. And we'll have the opportunity for the participants to ask clarifying questions and then provide recommendations to our case presenter. And then we will wrap up and have announcements for our next meeting. Before Dr. Olivier begins introductions of the hub team, I want to introduce myself. I am the coordinator for the ECHO and the program manager for PPCL. Provider consultation line is a telephone consultation and education program focused on pediatric and perinatal mental health. And we are statewide and free service. We do not take over the care of the patient, but we can help you with recommendations and connections to resources in your community, as well as connect you to our panel of experts, including mental health providers and psychiatrist to help guide you with your patient's care. So if you scan that code, it'll bring you to our website where you can register not only for future trainings, but also to receive consultation. Dr. Olivier?
Hey, good morning or afternoon, everybody. I'm Dr. Olivier. Thank y'all for joining us today. All y'all rolling in quick. 5 minutes ago, we had one person. So thank y'all for coming and giving up your lunch breaks. I'm a psychiatrist here in Lafayette, Louisiana, in private practice at Bloom Mental Wellness. I'm also the facilitator for the ECHO team. So I will be making sure we stick to the schedule and run things on time. I'm going to go through and ask each of our hub team members to introduce themselves. You just met Jody West. I'll also ask Katie Hebert to introduce herself.
Sure, I'm Katie Hebert. I am a licensed clinical social worker and perinatal counselor, working specifically with the perinatal community here in Lafayette, Louisiana at Bloom Mental Wellness.
Thanks, Katie. How about Dr. Zena?
Good afternoon, everybody. I'm Paula Zena. I am a nurse and a clinical psychologist, expertise in perinatal, infant, and early childhood mental health. I'm serving as a consultant with PPCL.
Thank you, Dr. Zena. And Dr. Finelli.
Thanks, Dr. Olivier. Hi, everyone. Juliana Finelli. I'm also at Tulane. I'm a general psychiatrist and a child psychiatrist. My focus is infant and early childhood psychiatry and perinatal psychiatry. And I work with PPCL as a perinatal psychiatric consultant.
Thank you. And we also have Dr. Vincent, who will introduce herself shortly. She is also presenting our didactic today, but we are your hub team of experts. And as we go through the presentation, we'll have a 20-minute didactic followed by a case presentation. And so I'll just ask you to hold your questions to the end. And Dr. Vincent, if you want to introduce yourself, then go ahead and take it away.
Hey, good afternoon, everybody. I'm Megan Vincent. I am a Tulane faculty member as well as a perinatal psychiatry consultant for PPCL. So I am going to be talking about addressing safety concerns in the perinatal period. You can go ahead and move forward, Jody. Thank you. Just wanted to mention a sensitive content warning. Due to this topic, we're going to be discussing some things, including suicide, intrusive thoughts regarding infant safety, and intimate partner violence. And you can move forward. Thank you. I'm going to be mostly talking about maternal suicide. There's a lot of research. There's a lot of research that's come out on it. It tends to be a question, or a topic that we focus on a bit in consultation. So just wanted to mention a few facts and what we do know. This is from the Policy Center for Maternal Mental Health. If you have not checked it out, if you're interested in kind of knowing more about what's going on behind the scenes in terms of advocacy and policy making, they used to be known as 2020 Mom. In fact, I think if you put that in, that still directs you to here. So they're now known as the Policy Center for Maternal Mental Health. So a lot of the kind of like infographics I'm going to be presenting in this first section are going to be from them. But we do know that suicide is a leading cause of death and of maternal death in the first year following childbirth. They're more common than deaths from postpartum hemorrhage or hypertensive disorders, and it can account for up to 20% of maternal deaths that occur during the postpartum period. The time frame the maternal suicide is most frequently completed between 6 to 12 months postpartum. So when we think about, when we're following patients, particularly, thinking about more like in the OB setting, for a lot of patients, they may have their initial post delivery visit, usually within the first month and a half. And if there aren't any other identified complications, they may not have another follow-up until a year later. Of course, we want to think about different settings, they'll where they may we may encounter moms, but something to kind of think about in terms of timing as well. You can move forward. In terms of what we know about certain populations and the risk for suicidal ideation, women who self-report as other race are 3 times more likely than white women to report suicidal ideation in the postpartum period. American Indigenous persons and Alaska Native persons are at very high risk of maternal death from suicide as well as other groups that are more likely to report suicidal ideation. Asian identifying and Hispanic and Black women as well have increased rates of reporting suicidal ideation. Okay, thanks, Jody. This was from I believe 2020 data collected from maternal mortality review committees, which some people may be aware of. They're multidisciplinary groups or teams that convene at the state level. They review deaths that occur within the first during or within the first year of the end of pregnancy, so or termed as pregnancy associated deaths. These review committees do have access to information such as their medical records, social service records, to more fully understand the circumstances surrounding the deaths, whether it was pregnancy related, and then developing action plans to prevent similar deaths. So this is data that was collected on over 500 pregnancy related deaths from 38 states. Then this data was collected together, shared with the CDC. So in terms of, sorry, my mouse isn't working. In terms of risk factors, or what were identified as risk factors, you can see history of substance use, previous history of psychiatric hospitalizations or treatment, unemployment, prior suicide attempts, exposure to trauma. So things that we want to be thinking of in terms of who might be at increased risk of suicidal ideation. Okay. So this hopefully this looks familiar to a lot of you guys at this point. This is the Edinburgh postnatal depression scale, and in terms of screening for depression, mood disorders during the perinatal period, we typically recommend either the Edinburgh or the PHQ-9. Both of these questionnaires have as their last question a question regarding the thought of harming themselves. So say you're in a clinical setting, you see this, and the patient responds, the thought of, yes, quite often the thought of harming myself has occurred to me. So where do we go from here? Okay. So I'm going to just kind of run through this really quickly because we could spend a whole other session talking about screening recommendations. I'm going to focus on the ACOG clinical practice guidelines, particularly where safety concerns or concerns about suicidal ideation come in, and what they are recommending. The American Academy of Pediatrics also has developed their own set of guidelines. So I don't know if we have anybody in this session who is in a pediatric setting, but they also have their recommendations as far as screening and recommended support for parents who who have positive screens in their setting as well. So, okay, Jody, go ahead. And again, we talked about this already, the recommendations for everyone receiving pre-pregnancy, during pregnancy and postpartum care screening for depression, anxiety, using standardized validated instruments such as the PHQ-9 or the Edinburgh, recommendations that this should occur at the initial prenatal visit, at minimum at the initial later in pregnancy, and at postpartum visits. Go ahead, Jody, thank you. And then another recommended another screening recommendation is that everyone receiving prenatal and postpartum care be screened for bipolar disorder, again using a standardized validated instrument. We typically recommend either the mood disorder questionnaire or the CD screen before initiating pharmacotherapy such as an antidepressant, and consulting access programs such as ours in the event of concerns for a history of or positive screen. Go ahead, please. So here's kind of where I wanted to focus in terms of where the current guidelines are in terms of postpartum psychosis, which we're not going to focus on as much today, but is something something we need to be aware of, as well as suicidal ideation. So the ACOG guidelines recommend immediate assessment for likelihood, acuity, and severity of risk of a suicide attempt when someone answers that last question as any level of yes, regardless of the frequency. And then recommending providing immediate medical attention for postpartum psychosis, and obviously any safety concerns. I'll talk about screenings on another slide. So you can go ahead, Jody. So some considerations around safety or risk assessment if someone does have a positive response on a screen such as the Edinburgh or the PHQ-9. Some suggestions for questions about the frequency that someone has been experiencing these thoughts, asking about some ways in which they could potentially harm themselves or attempt suicide, asking about past history, because as I mentioned in that previous slide, a past history puts someone at higher risk of developing suicidal ideation in the future, and then asking about prevention or reasons for living. So what prevents someone from acting on these thoughts? And then if any response does raise concern about the safety of the parent and or infant, never leaving them alone until the full assessment can be complete. And talking about an action plan, referring to emergency services as indicated. I want to focus on this area of kind of like high risk, some features that have been associated with a higher risk in terms of suicidal ideation. So when the thoughts are persistent, when a current intent or desire to end one's life is expressed, or someone has developed a plan, or even taken some preparatory steps, such as giving away things, like writing letters, things like that. Those should all be huge red flags in terms of safety concerns. Again, we talked about history of not just suicidal ideation, but actual suicide attempts should raise further concern. History of psychiatric hospitalizations, expressions of hopelessness or helplessness, not identifying as being future oriented, limited protective factors, like especially in terms of, social, maybe social supports, concurrent substance use, and anxiety or agitation or high impulsivity. Okay, go ahead. And it kind of, some recommendations in terms of more follow-up screening. The safety or the Columbia protocol has been actually implemented or incorporated, I know, into some medical record systems. Some of the ones that you guys use may already have these. They're both available. The Columbia protocol is on the left there. And then the safety, this is kind of a little nice pocket card that they provide. They are both available as free apps that you can use as well. And like I said, hopefully, or at least from what I've seen, a number of medical record systems are now kind of incorporating them. So in terms of risk stratification, if asking just open-ended questions seems like a lot or kind of daunting, these are some recommendations for using conducting a safety assessment as a follow-up if someone is endorsing thoughts of harm to self. Okay. So next steps, again, I'll kind of highlight the, in the high risk category, reinforcing the disclosure, emphasizing that, you're there to help the person, and what our next steps are. Obviously it can be, a very, stressful situation, but emphasizing that we're here to help, not leaving the mother and baby alone until a safety assessment is complete, and then referring to emergency services in the case of, when there are high concerns, kind of based on those risk factors that we talked about, referring to emergency services as needed. The Stanley Brown safety plan has been recommended in terms where, or in situations where it's determined that the person is not at imminent risk of harm to self, but certainly has a number of risk factors. So walking through with that person, what are some supports they can lean into, what tools can they use during a potential crisis. And coming up with a plan collaboratively to ensure that that person has the right supports when they need it. Okay, I'm realizing we're coming up on time. So when there is a potential concern about harm to others, particularly harm to infants, a large proportion of women will report unwanted or intrusive thoughts. They may express that during the perinatal period. There are lots of reasons that someone could have those thoughts. Sometimes they may be due to anxiety, or perinatal OCD, which is very different than thoughts of harming the baby that are due to psychosis or delusions. The following, follow-up questions can be helpful in determining who may be at lower risk versus high risk. More high-risk situations are things such as thoughts of harming the baby or comforting, or what we refer to as egosyntonic feelings, as if acting on those thoughts will be helpful in some way. A lack of insight, the person may have more, may also have some symptoms of psychosis, such as hallucinations, or other beliefs that are not reality-based. Okay, you can go ahead. And then in terms of these high risk situations, obviously it's, it can be an emergency situation. Safety, safety is a priority here. And again, emphasizing not leaving the patient and the infant alone until help is obtained. and then oh, sorry. And then and then if they're if they're determined to be lower risk, coming up, coming up with a safety plan, as we discussed earlier, is key. Okay, go ahead. Again, I'm sorry, I'm just breezing through these, you guys. I wasn't good at gauging my time. These are kind of like 3 talks in one. One last thing I wanna emphasize is intimate partner violence, or IPV. We know that these individuals are less likely to receive routine prenatal care, but when they do, they are at higher risk of being identified for postpartum depression, other pregnancy-related complications. Unfortunately, homicide is also a leading cause of death in pregnant women in the United States. You can go forward, Jody. I think this is my last slide. No, second to last, I think. The recommendation again from ACOG is that all women should be screened for IPV at periodic intervals, offering ongoing support, signs of depression, substance use, mental health problems, requests for repeat pregnancy tests, new or recurrent STIs should prompt an assessment for IPV. Go ahead. Okay. And then again, as far as screening recommendations, we have this tool shared on our website as well. It's the HITS. Things that we want to think about are screening in a private setting, using professional language interpreters and not someone associated with the patient, emphasizing that this screening is offered to everyone. Considering incorporating screening questions on intake forms so that, again, there's universal screening. Thinking about keeping take-home or resource materials, hotline numbers in areas that are easily and privately accessible, and including the statewide and local resources on screening forms with patients. Okay, I think that's it. That was very quick. I apologize for my not great timing.
Are you kidding? You did great. We actually have time, a couple minutes for questions. So anyone with questions about safety? And thank you, Dr. Vincent, for the didactic presentation. Jody or someone from behind the scenes will be typing up all the recommendations and emailing it out to everybody. So thank you for your hard work. Appreciate it.
Yeah, thank you, Andrea and Dr. Vincent. We're going to go ahead and put the survey into the chat for everyone to fill out. Even if you don't need CEUs, we ask that you fill out the evaluation just to help us improve the program. But once you do fill out the evaluation, you will get an opportunity to present a certificate of attendance and for CEUs and CMEs. But our next session is on September 27th, and let's see who's going to be Jenny Thompson is going to just discuss the role of doulas when it comes to labor and birthing and pregnancy. And then I believe we have a case presentation lined up for that time. But once this is, like Dr. Olivier said, we will send out the recommendations as well as the link in case you miss it. And then we'll keep you notified of the next session. So thank you everyone for attending. Thanks again to Andrea and to Dr. Vincent for presenting their situations and their didactics today. We hope everybody has a good afternoon, and we will stay on the line in case anybody has any questions in the next few minutes. Okay, thank you. Bye.
Bye. Thank you.